Standoff, stand-in. If you've stood at a kilovoltage set, heard these terms, and just quietly nodded along, this one's for you. In the next few minutes, I'll show you what they mean, why they matter, and how to get the correction right every time. And the good news, it all comes back to one thing you already know: the inverse square law. First, the setup. In kilovoltage radiotherapy, we treat through applicators, cones with a fixed focus to skin distance, or FSD. Very often, that's 30 centimeters. The machine is calibrated so that when the end of the applicator sits flush against the skin, a known number of monitor units delivers your prescribed dose right at the surface. The problem is, skin is almost never flat. Noses, ears, eyelids, scalps, post-op defects, they all curve. So the surface you're actually treating often isn't sitting neatly at the end of the cone. And that mismatch is exactly what standoff and stand-in describe. Here they are side by side. On the left in standoff, there's an air gap between the applicator and the skin. On the right, stand-in, tissue bulges up into the applicator. Let's take them one at a time. Standoff first. When there's a gap, the point you're treating sits further from the source than the machine assumes, and further away means a lower dose rate, inverse square again. So to still reach your prescribed dose, you have to give more monitor units. We record standoff as a positive gap, and the correction factor is greater than 1. Now stand in. Here the tissue pushes up into the cone. The classic example is treating the tip of the nose. The tip pokes into the applicator, so the point you're treating is now closest to the source, and it gets a higher dose rate. To avoid overdosing it, you give fewer monitor units. Stand-in is recorded as a negative gap, and the factor is less than 1. If you take one thing away, take this. Stand off. Further away, less dose. Dial your monitor units up. Stand in, closer in, more dose. Dial your monitor units down. And watch for the bit that trips people up. The further away the surface, the more monitor units you give. It feels backwards until you remember you're compensating for lost dose, not piling extra on. In practice, you'll use a table like this, the standard correction for a 30 centimeter FSD. The size of the gap is signed. Negative for stand-in, positive for standoff. You find your gap, read across, and that's the number you multiply your monitor units by. So a half centimeter stand-in is times 0.97. A 2 centimeter standoff is times 1.14. And a zero gap, surface right, at the applicator end, is times 1. No correction needed. Let's make it concrete. Tip of the nose protruding half a centimeter into the applicator. That's a gap of minus 0.5. Multiply your monitor units by 0.97, a 3% reduction so you don't overdose the tip. The other way round, a 2 centimeter air gap over a concave defect, a gap of plus 2. Multiply by 1.14, a 14% top up to make up for the extra distance. Same principle, opposite direction. And now, the payoff. That entire table? It's nothing more than the inverse square law applied to a 30 centimeter FSD. The factor for any gap is FSD plus gap over FSD, all squared. Gap positive for standoff, negative for stand-in. Let's check it. Plus 2 standoff, 32 over 30 squared, 1.14, minus 0.5 stand-in, 29.5 over 30 squared, 0.97. Exactly the table values, which means if you remember the FSD and inverse square, you can rebuild the whole thing from scratch. No rote learning required. That's why examiners love surface corrections. They're testing whether you understand the physics, not whether you've memorized a number. So if you can explain why standoff needs more monitor units, why stand-in needs less, and reproduce that calculation from the FSD, you're in great shape. If that helped, hit subscribe. I'm breaking down the clinical oncology physics that actually turns up in the FRCR. And when you're ready to practice questions exactly like this one, everything's waiting for you over at the oncology residence. See you in the next one.